So hello, everybody. We want to announce that Term Therapeutics offers 3 internship positions in the summer 2024 through the Medical Technology Internship 1 and 2. So if you are interested, this is a 12 credits, 6 credits course, 12 credits in total. Send us your CV by the end of March. And if you are selected, you'll receive permission to register. So please keep your camera active during the seminar. If you have a strong academic record and you are interested in pursuing a PhD, we invite you to fast track for the fall 2024. Supplemental tuition assistance, it's available, minimum $2,000 for eligible fast track students in the academic year 2024-2025. Our last announcement is regarding Research Day by Surgical and Interventional Science Program. Following many requests, abstract submission deadline is now extended to Monday, 25th March. Please don't forget to register for the Research Day and also for the dinner. Thank you.
So it is with great honor that we introduce today's speaker, Dr. Bettina Willie, a distinguished leader in the field of dental medicine and oral health sciences. She currently serves as the Professor and Associate Dean of Research and Graduate Education in the Faculty of Dental Medicine and Oral Health Sciences at McGill. So her remarkable career also includes a vital role as an investigator at the Shriners Hospital for Children. Dr. Willie's academic journey is both impressive and inspiring. She holds a PhD in bioengineering from the University of Utah, where she laid the foundation for her research. Her pursuit of excellence continued with her postdoc training at the University of Ulm at the Hospital for Special Surgery, further enriching her expertise in skeletal research. And before joining McGill in 2015, she spearheaded a research group at Charité Universitat Medicine in Berlin for 8 years, where she made significant strides in the understanding of skeletal fragility. Her commitment to advancing our knowledge in this area is evident through her multidisciplinary research program. She uses state-of-the-art, high-resolution imaging technologies. Her team is at the forefront of studying the causes, detection, and treatment of skeletal fragility. Her work is driven by a deep interest in how this local mechanical environment influences bone formation, adaptation, and regeneration during skeletal aging and in rare bone disorders. So this has not only contributed to our scientific community's understanding of these complex processes, but has also opened new avenues for innovative treatments. In addition to her research, Dr. Willie is an associate member of McGill's Department of Biomedical Engineering and Department of Surgery, where she continues to inspire and mentor the next generation of scientists and medical professionals. Please join me in welcoming a visionary and in the field of bioengineering and skeletal research. Dr. Bettina Willie, please.
Great. Thank you, Dr. Malawi, for that really nice introduction. David's just going to get this set up. So I'm going to give a bit of the presentation, and then David, who is doing his PhD in the Department of Surgical and Interventional Sciences, will then jump in and present one of his projects that involves bone adaptation to mechanical loading in OI. And then I'll finish off the talk talking a bit more about some clinical studies that we've done on this topic. So I just want to make sure you can see my screen. Is it?
Yes.
Okay, perfect. Great. Let me just advance. Oh, I'm going to have to advance this way. Minimize this. Okay, so here are my disclosures. Oops. Okay, sorry, little technical issues here. Okay, so as Dr. Malawi kindly introduced, my research is really involving multidisciplinary approaches using state-of-the-art high-resolution imaging technologies. So this includes micro-CT, something called HRPQCT, which is high-resolution peripheral quantitative computed tomography, and with the end goal of studying the causes and improving the detection and treatment of skeletal fragility. And as he also mentioned, I work at the Shriners Hospital, right, where we are treating children with rare bone diseases. And I'm particularly interested in how the local mechanical environment influences bone formation and regeneration, so during bone healing also, during skeletal aging, but in particular during these rare bone disorders. And so these are the 4 current themes that I'm working on in my lab. And we're going to just focus on today this 4th one, investigating in rare bone diseases, skeletal fragility. Okay. And so I first want to introduce you to this disease called osteogenesis imperfecta. It affects about 25,000 to 50,000 people in the US. The prevalence is about 1 in 10,000 births. And people with OI have frequent long bone fractures. And also these are vertebral fractures as well, and deformities. So you can see deformed limbs here that have to be corrected with an osteotomy and a rod put in. And they also have a lot of dental problems. And in about 90% of cases, they're caused by mutations in COL1A1 or COL1A2, and this results in abnormal type 1 collagen produced by osteoblasts. So the current standard of care in children with osteogenesis imperfecta, or OI, is a bisphosphonate. And what the bisphosphonates do is, in general, they block bone resorption. So they block osteoclasts, these cells, from removing bone. Okay? And so the pediatricians here at Shriners Hospital in Montreal, they've done amazing work over the years. They're really leaders in the field. And you can see this study in the New England Journal of Medicine by Dr. Glorio in 1998, where they showed that bisphosphonate treatment could improve bone mineral density in kids with OI. And then since that time, Dr. Rausch, who is also a pediatrician here, he's continued to show that bisphosphonate treatment, especially when started early and continued throughout the growth period, has a good effect on improving vertebral fractures, so preventing vertebral fractures, but less of an effect on preventing long bone fractures. And so, you know, what is the reason? Why does bisphosphonates, why do they do a better job in the vertebrae rather than in the long bone? And it really comes down to geometry. And so you can see this is a PQCT machine, so peripheral quantitative computed tomography. And from the images, this is from a healthy child, and this is a child with OI. And you can see that the bone in the child with OI is much smaller. So the cross-sectional area is much smaller than the healthy child. And when you look at these graphs here, you can see that kids with OI, they have even higher bone mineral density than the average, but they have consistently lower cross-sectional area in the diaphysis, which is the middle part of their bone. And if you look at this graph, Dr. Rausch also showed that, you know, there are different severities of OI. So there's type 1, type 4, type 3. And so type 3 is the most severe and type 1 is the least severe. But all of regardless of severity, they all have these smaller bones, this cross-sectional area. And so, you know, you can see why this simple example that a bone that has a smaller diameter is easier to bend or fracture. And that's really, you know, so what is determining the cross-sectional area? And that's periosteal apposition. And thus, we believe that that's a likely key factor in osteogenesis imperfecta long bone fractures that's not improved by bisphosphonate treatment. And so what are possible causes of this periosteal apposition defect in people with OI? So one possibility could be that osteoblasts can't produce enough bone. But that is not true because Dr. Rausch has already shown that actually the bone formation rate is increased, and a defect in an individual osteoblast is actually compensated because people with OI have an increased number of osteoblasts. And I should mention for you out there that don't know, osteoblasts, right? They're the bone forming cell. So they produce, so they're forming the bone, and the osteoclasts are the cells that are resorbing the bone. So people with OI have actually a higher number of osteoblasts. Could it be that there's just decreased loading in people with OI? So, but that's also not the case because kids with mild OI, they have similar levels of physical activity as their peers. And also this smaller cross-sectional area, it also affects the arms, so the upper extremities, where loading is pretty much similar between people with OI and healthy individuals. So what we think is perhaps there's a decreased response to loading, and that's what we are interested in investigating. And so just to get you on the same page, I'd mentioned, you have this diagram, this is a piece of bone, and you have these osteocytes inside the bone, and then you have the blasts on the surface here, and they're forming, so they're forming bone, and the osteoclasts are resorbing bone. And the osteocytes, here, this is a piece of mouse bone, and you see all these little holes. So these bigger holes are blood vessels. This is a micro CT image. And these smaller holes are called lacunae. And inside the lacunae are these cells, these osteocytes. So they're like these mechanostrain sensors inside the bone. And you can see how plentiful they are. So they're all throughout your bone, and they're sensing the mechanical strain. So if you start jumping up and down, you're loading your bone, and that load is then converted to a mechanical signal. It's like matrix strain. So the bone matrix is straining, and also the fluid flow. So fluid within this lacunae is moving around, and the osteocytes are sensing the shear strain. Okay, so then the osteocytes, they sense this, and they convert this mechanical signal into a biochemical signal. And we have some ideas of certain biochemical signals, but I won't go into too much detail there. So the biochemical signals are then transmitted from the osteocyte to the osteoclasts and the osteoblasts, where they then perform the producing more bone or resorbing the bone. So you have this amazing mechanism in bone to increase your bone mass or decrease your bone mass based on the amount of mechanical stimuli. And this is really summarized in this theory called the mechanostat. It's kind of like a thermostat is how you can think of it. So during daily activity, you're just maintaining your bone mass. But as you load your bone, like a tennis player, they have denser, thicker bone in their playing arm, because as they load that playing arm with a higher mechanical stimulus, the bone starts forming. Okay, and the other direction, so if you have an astronaut that's not putting loads onto their skeleton, or someone that's stuck in bed for a certain period of time because of an illness, they're going to start losing bone mass because they have less mechanical stimuli. So, these mechanical loads are regulating the amount of bone resorption and formation that you have. Okay? So if we put this OI, this disease, in the context of the mechanostat, we can think about that, OI, some have postulated that OI might have a higher set point to induce an anabolic response. We know that the bone is hypermineralized. It also has a higher Young's modulus. So maybe that results in a lower than normal deformation to load. So the osteocytes are underestimating the load to which the bone is exposed. Okay. So now David is going to take over and show a project. So this is one project within his PhD program. And let you just change seats here.
Okay. So like Bettina mentioned, I'm just going to go over a study that sort of is part of my PhD thesis and sort of delves a little bit more into this this reduced cross-sectional area that we see in OI and potential altered mechanoresponse. So the primary aim of this study, so this is a mouse study, and the objective here was to determine whether the bone formation response to 2 weeks of in vivo loading was altered in OI compared to their wild-type littermates. So in other words, we load the mouse bones over 2 weeks and then see what kind of formation happens in OI versus wild-type mice. Our hypothesis, of course, was that the OI mice would exhibit a lower periosteal bone formation response when compared to their wild-type littermates. And so just to mention, before we dive into the experiment here, we're actually carrying out this experiment on 3 different mouse models of OI. But what I'm going to be focusing on with our results today is this brittle mouse model that we have here. So this is a point substitution in the COL1A1 gene. So as Bettina mentioned, this is one of the genes that encodes type 1 collagen, specifically the alpha-1 chain. And so this results in sort of a moderately severe form of OI in these mice. So before we sort of get started with the loading portion of the experiment, what we have to do is make sure that we select a load level that gets us into sort of this region of the mechanostat curve that Bettina just mentioned. So in other words, we need to make sure that we are engendering a strain that is resulting in a formation response in these bones without actually overloading or fracturing these bones. So in order to do that, the first thing that we did was a strain gauging experiment. So essentially what we did was we attached a strain gauge to the anteromedial surface of the tibia, shown here. And then for the first portion of the experiment, we just wanted to see what sort of strains were engendered from everyday sort of locomotion of the mouse. So after the surgery, we simply allowed the mouse to wake up. And then using the strain gauge, we were able to measure the strains that were engendered from the mouse taking regular steps while walking. And so the next thing that we did, in addition to that, so this is very important for the subsequent loading experiment, we wanted to determine the relationship between strain and load. And so with the strain gauge still attached, we placed the mouse's leg into this, we anesthetized the mouse, placed its leg into this loading device shown here, capable of applying cyclic compressive loads. And so we applied loads of a known magnitude, so known force in newtons, and measured the resulting strain. So this allows us here, as you can see, to quantify this relationship between compressive force and resulting strain. And so this is a parameter that we call in vivo stiffness. And what we saw was that the in vivo stiffness was actually quite similar between the brittle mice and their wild-type littermates. And so with that, we were able to move on to and select our parameters for the loading experiment. And so what this was essentially was a 2-week experiment. We took 10-week-old female brittle mice and their wild-type littermates. We had an N equals 10 of each genotype. And we subjected them to, so this loading experiment is shown here in red. So we loaded the left limb in the same device that I presented previously. So cyclic compressive loads at 10 newtons, which based on our strain gauging data corresponds to about 1500 microstrain. And we subjected them to 5 days of loading, 2 days off, another 5 days of loading within our 15-day experiment. So our analysis of the subsequent bone formation was primarily carried out via in vivo micro-CT at several time points. And we also performed activity analysis as well. So sort of just within a given amount of time, measuring distance traveled and the amount of rearing. And we also administered calcine at 2 different time points, which is a fluorochrome label. So you can see an image here of the kind of thing that this can be expected to produce. And this is just another way through histomorphometry of measuring bone formation. Okay, so diving into some results now. What we have here are micro-CT results. And this first slide, I'm just presenting some baseline data, so at day 0. And the purpose here really is just to, before any loading has occurred, compare our 2 mouse genotypes, right? So as you can see, in the brittle mice compared to their wild-type littermates, we can see a significantly reduced cortical thickness, total cross-sectional area, and cortical area at baseline when compared to wild-type littermates. And so this is very much what we would expect to see in this mouse model of OI, right? Now, looking at the results from the loading experiment itself. So all of the parameters that I'm presenting here are deltas. So day 15, the endpoint after loading, minus day 0, the baseline. And so we have non-loaded limbs in white, loaded in blue. And what we can see looking at the delta cortical area and change in cortical thickness, for example, we can see that the change in these parameters was significantly increased in the loaded limb for both wild type and brittle mice, as we would expect. However, looking at the total cross-sectional area, what we see, interestingly, and in line with our hypothesis, is that, again, the change in total cross-sectional area was increased in the wild type mice, but not in in the loaded limb in the wild type mice, but not in the brittle mice. So that relationship was not significant. So yeah, we can take this a little bit further also than just measuring static parameters with our micro-CT scans. What we can also do is look at what's called time-lapse morphometry, right? And so essentially what this entails is taking our scan at the endpoint, in this case, day 15, and registering it on top of the baseline scan at day 0. And then from there, we just compare voxels. So take, for example, a voxel in the image that was not present at day 0 and then is present at day 15. So we can assume that to be formed bone, and we can label that formed bone in our analysis. Then let's say there's a voxel that is present at day 0 and also at day 15. This would be quiescent bone, so not formed or resorbed. And finally, a voxel that is present at day 0 and not present at day 15, we can consider that to be resorbed bone. And so this is also shown in this nice little video that we have here. Yeah, there we go. So this is actually trabecular bone instead of cortical bone, but I think it still exemplifies the point here. So first we segment the bone that we want to analyze, then we can perform time-lapse analysis showing any formed or resorbed bone. And we can perform this analysis with however many time points that we happen to have. So that's really the advantage of in vivo micro-CT when compared to just ex vivo micro-CT at the end, for example. And so we applied this principle to our own data shown here, so to our own scans. And so we have some images here. So before moving on to quantitative analysis, what you can see, for example, is that we see strikingly more bone formation in the loaded limbs when compared to the non-loaded limbs, as we would expect from the mechanostat, as Bettina mentioned. We can also see, for example, that there's just more resorption in general in the brittle mouse model when compared to the wild-type mouse model. But looking at actual quantitative data here, so the parameter that I'm presenting is the mineralizing volume over bone volume. So essentially, in the previous slide, the blue voxels normalized to the entire bone volume, right? And so looking first at the endocortical surface over here. So this is the sort of interior surface of the bone shown here. What we can see is that that bone formation is significantly increased in the loaded limb for both wild type and brittle mice. However, when we look at the periosteal surface, so of course the outer surface of the bone now, what we see is that bone formation is significantly increased in the loaded limb for wild type mice, but not for brittle mice. So once again, in line with our hypothesis. So now we've shown a little bit of data that seems to suggest that there's an altered mechanoresponse on the periosteal surface in OI. But then the question becomes, what could be the underlying mechanism at play here exactly? So we know quite well at this point from previous research, as Bettina mentioned, that the osteocytes and the lacunae and the canaliculi in which they exist, so this is what we call the lacuno-canalicular network. This network is very, very important in determining mechanoresponse in bone in general. And so we've seen in the past from a few studies, so for example, some electron microscopy has been done that seems to suggest some alterations to the lacuno-canalicular network in OI, but really not a lot has been done in this space at all. So we really need further analysis to see what exactly is going on here. And so that is where the second aim of this experiment comes in. So we aimed really to determine whether the osteocyte lacuno-canalicular network architecture was altered in these brittle mice when compared to their wild-type litter mates. And so that's an analysis that's a little bit beyond the capabilities of the sort of conventional micro-CT that we carried out here at the Shriners. So once we had our dissected tibias from the end of the experiment, we actually took these to the European synchrotron radiation facility in Grenoble, France. So this is a big particle accelerator, essentially, this building over here. And then we subjected the samples to synchrotron tomography. So you can really think of this as very high energy, high contrast, high resolution CT scans. And it allows us to produce these really beautiful images where we can actually visualize and resolve individual pores within the cortex. And then based on their size, we can classify them as being either lacunae or vascularity, right? And this is really an amazing analysis because let's say for a given region of interest, we can actually quantify certain parameters related to the lacunar network and also related to the vascularity as well in terms of morphology and also density. So now looking at some quantitative parameters. So we're looking at our lacunar parameters here. And first we're looking at the full volume of the region of interest. So this would be all three of the compartments that we're showing over here to the right, for example. And so looking at the full volume, what we can see is that in these OI mice, in the brittle mice, we can see a significantly increased lacunar number density and a significantly decreased individual lacunar volume. So essentially we have more lacunae, but they're smaller. Interestingly though, when we look at just the periosteal surface, what we see is that this increase in lacunar number density is no longer present in just the periosteal surface. Finally, I just want to mention some ongoing work that we have. So we're also performing a little bit of a more in-depth analysis, I suppose. So where we took our tibias, we stained them with rhodamine, and then this also involves confocal microscopy as well. And so we can produce these really beautiful images, a Z-stack of images that look like this, where we can see not just individual lacunae, but even the canaliculi, so the little tunnels in bone that connect the lacunae. As we mentioned, the structure, the overall structure of not just the lacunae, but the network in general is what's so important in mechanosensation. And so from here, we can, with these images, we can perform a network analysis. So, for example, we can designate the intersections between canaliculi as what we call nodes. We can also perform this analysis on lacunae as well. And just the kind of output that we can get is these quantitative parameters that describe the network. So as far as node degree, node number, and canalicular density, we can also output some lacunar parameters as well. So this is a really powerful technique when it comes to analyzing the network as a whole. So just in summary, what we saw was that there appears to be an altered periosteal bone formation response, an attenuated response in the brittle mice when compared to their wild-type litter mates. And we also saw altered lacunar properties in the periosteal compartment when compared to the remaining cortical volume of these mice. And so these alterations to the mechanoadaptive response and also to lacunae that we're seeing in these brittle mice may help to explain this smaller cross-sectional area that we're seeing in OI patients and thus some of the reduced fracture resistance. And then I'll pass it back to Bettina.
Great. Great, thank you, David. So you can see some really nice work that he's been doing, looking at, observing this reduced response and then also looking at mechanism. And I should mention that he is also looking at molecular mechanisms, so doing RNA-seq and examining that as well. But we decided not to go into that in today's lecture. So that's some preclinical, so some animal studies where we're looking at this topic in OI. And so what I want to show you now is some clinical work from my group. And so there is a particular protein called sclerostin. The gene is called SOS. This is produced by osteocytes, almost exclusively by osteocytes, and it inhibits osteoblasts. And you can see from these images, this is a healthy person, their skull, and sorry, this is a healthy person right here. And then you can see the image here is from someone with sclerosteosis. And so they have an inactivating SOS mutation. So you can see how much increased bone mass they have. And so there is a neutralizing antibody that's been developed by several pharmaceutical companies to block sclerostin. And this neutralizing antibody, it blocks sclerostin, and doesn't allow sclerostin to inhibit Wnt signaling. And Wnt signaling is a major signaling pathway whereby we get increased bone formation. So I'm going to talk a little bit about using this drug to try to improve bone mass in people and animals with OI. So some exciting data that has come out, you can see in 2019 and more recently in 2023, showing that sclerostin neutralizing antibody could actually enhance. So these are in mice, OIM mice, so a mouse model of OI. We could see enhanced periosteal apposition in these animals. And then Dr. Rausch's lab, he used a genetic sclerostin inactivation in mice with OI. And this was in a severe mouse model, so a mouse model with severe osteogenesis imperfecta. And he was also able to show this increased periosteal apposition or bone formation. So, as David showed you before, we believe that there's this reduced response to loading because that leads to this altered periosteal apposition, which is why they have the smaller bones. And so now we have a treatment that could potentially, we're showing this in the mice, increase periosteal bone formation. So a clinical trial started in 2017 in people. So this was in adults with OI, and this was a phase 2A study in 14 adults with OI. And it lasted 21 weeks, where the patients were given cestrucimab, which is the sclerostin neutralizing antibody. And what we could see that it increased the lumbar spine. And we also were able to see that the bone formation marker P1NP increased 84% from baseline to day 43. And interestingly, it also, the drug led to reduction in CTX, which is a bone resorption marker. So it increased formation and it decreased resorption. So this was a small study. So this was followed up in it started in about 2017, but we actually just did the second revision on it. So hopefully it's going to be published any day now. But this was a bigger trial. So you see 112 patients. We did a dose finding study. So we looked at 2, 8, and 20 milligrams per kilogram of the sclerostin neutralizing antibody. And I got involved because my lab was asked to be the central reader for all the HRPQCT. So this is a form of micro-CT, right? But it's used in patients, so high-resolution peripheral quantitative computed tomography. And we were measuring radial trabecular volumetric BMD and bone strength as the primary outcomes. And these were really outcomes as surrogates to fracture in adults with OI. And we were focusing on type 1, 3, and 4 because these are the most common types. And as I mentioned, type 1 is the least severe, and type 3 is the most severe, and 4 is moderate. And so we measured HRPQCT. So they were on treatment for 12 months, and we measured at baseline 6 months and 12 months. And there is also a period, a 12-month period of follow-up, where we also measured at 18 and 24 months where they were off treatment. But I'm not going to go into that data today. So just to show you some of the results from this study, you can see here that the bone formation marker, P1NP, was increased, and this was in a dose-dependent fashion. And we also saw the bone resorption was decreased here. It was a little, not exactly dose-dependent, but it was in the early time points. And we also saw significant improvements in lumbar spine aerial BMD. So this was with DEXA. And these improvements were also seen in the less severe as well as the more severe cases. So this was really quite promising. And so, as I mentioned, my group was tasked with analyzing all of the HRPQCT data. So what can we see with this? So it's really similar to micro-CT. Some of you are familiar with that when you're looking at animals, your in vivo micro-CT. So While in mice, we can get to a voxel size of about 8 microns. In humans, because of radiation exposure, we're really limited to 61 microns, but still quite amazing. And the scan time is around 2 minutes, right? All to minimize the radiation exposure. And the outcomes that we can get are volumetric BMD and all these microarchitectural parameters that, again, are very similar to what you measure in the mice, right? Cortical thickness, trabecular number, trabecular separation, porosity. And then another exciting thing we can get from this data is we can take the images and we can do finite element modeling and actually estimate the bone strength and stiffness. So some of you are probably more familiar with DEXA, and I mentioned this before. So this gives you an aerial BMD. This is kind of, everyone's grandmother has probably had a DEXA scan just to monitor for osteoporosis. It's a standard method. It's really easy to do. It gives you one measurement of BMD, so it's simple for the clinicians to interpret, but it has a lot of limitations compared to HRPQCT. And one thing is it doesn't differentiate between cortical and cancellous bone, and there's also no information about the microarchitecture, so all you get is the BMD. And also because it's aerial rather than a volumetric measurement, it's size dependent. The other technology you may be aware of is just called PQCT. So not high resolution, but still PQCT. And that does give you a volumetric measurement, but it's at a much lower resolution. And again, the microstructural outcomes are limited. So you can get a cortical thickness, but there's really no microstructural parameters. So back to the study, the clinical trial. So we saw some of the results with HRPQCT. So in the radius and in the tibia, we saw dose-dependent improvements in the volumetric BMD in both of those bones. I should mention also, you see how this machine has this bore hole right here. So we're only able to measure the extremities, right? The radius and the tibia. Whereas that's another advantage really of DEXA is you can also see the spine, right? So that's one thing. But I digress. So we saw this nice increase in BMD, dose-dependent increase with this drug in these people with OI. And we also saw improvements in failure load, which is another name for bone strength. And so this was really quite exciting data to show that we could, with this drug, improve bone mass in these patients. And so the next step, right, this was a study in adults. So the next step is then to go to kids, because with osteogenesis imperfecta, the disease, you have a lot higher fracture rates in children. And so this is where it's really needed. But obviously, a lot of times when you're worried about safety of a certain drug, you start out with the adults and then you transition to the studies in kids. And so this study is ongoing, and they're looking at kids age 5 through up to 26 years old. They're not really kids at that point. But the early results that we've been shown are that there's improvements in BMD and a 67% reduction in fracture after 6 months of treatment, which is great. And then the nice thing about this study, in our adult study, whereas we were looking for surrogates of fracture, because the adults aren't fracturing as often, so we had to look at BMD and estimated bone strength. In this study, it's actually powered to look at number of fractures. That's the main outcome. And so when we see the 67% reduction with the treatment, that's quite exciting, because this is a really horrendous disease with these kids fracturing. You can imagine as often as they're fracturing how difficult that is. So if we can reduce the number of fractures, this is great. So we'll see, the results. That was only at 6 months, the early results. So we'll hear about that in about a year, what's actually going on with that from the full study. But now I just wanted to show you some technical studies that we performed in my lab, because we had access to this amazing data set, right, of all these patients. And so, as I mentioned, this was a 2B clinical trial. And so we had 24 clinical sites, and there were, so the clinical sites where they were recruiting patients, and then there were 13 scanning sites, so 13 HRPQCTs across Europe, the US, and Canada. And what they would do is, they were recruiting the patients, scanning the patients, and then we were troubleshooting problems they had and also having them send all the data to us. Well, while we were doing this, because we have all these scanners, we needed to understand with any multi-center study, the precision, and we also have to do cross-calibration between the scanners. And so this was the first and the largest by far. There was one other study that had like looked at 2 scanners, where we were looking at all these 13 scanners. So we sent these 2 different imaging phantoms to the different centers. So we would send it to them, have them scan the phantoms, and this went on every 6 months throughout the trial. And then we also had a group of patients, so we had 29 of the participants of the trial, where they would have do same day repeated scans. And this is where we could look at the precision. So if they're doing a scan, and then they get their arm out of the machine and then they do another scan, right? There's no biological change, bone formation or resorption that occurs over that few minutes that they're doing the scan. So we can actually measure what is the precision of the machine, right? So we can do intra, and we can do this across the patients. And so just to show you some of the results here, you can see that how the various HRPQCT outcomes are affected by the different sources of error. And so with the registration, so in the red, you can see that image registration using this cross-sectional area compared to no registration, it improved several parameters. These are the ones in the red were improved significantly. We can see the scanner generation. So there were 2 generations of the scanner, one with a 60 micron voxel size and the other with an 80 micron voxel size. And so we could see that these parameters were really sensitive to that improved voxel size. These are not surprisingly the trabecular parameters. And we also saw that motion artifact was detrimental, had a detrimental effect to almost all of the parameters. And then interestingly, OI type did not have an effect. So a person with a more severe disease, didn't have any difference in precision to that with a less severe disease. So when I was talking just a second ago about registration, cross-sectional area and 3D registration, I just want to explain that a little bit. So since it's a longitudinal study, where we're taking the images over time in the same participants, we need to look at the same volume of bone over time. And that's because every time these participants are scanned, right, there might be some repositioning error that occurs, either rotational misalignment or translational misalignment. And there are 2 types of registration. So the default that all these HRPQCT machines use is this cross-sectional area registration, and that corrects for the translational misalignment. So what we did was we developed a technique to look at 3D registration, to use 3D registration, which corrects both the rotational and the translational misalignments. Okay. And what we showed was that we could actually, the 3D registration actually improved precision compared to the cross-sectional registration. And I should mention that all of the scripts and the methods that we created for this trial and throughout, we have made available on my lab's GitHub site. So I'm really a proponent of open science and making these tools available so others can benefit, especially with methodologies. It's really important that you make your codes and scripts available for other people. And so now I want to talk a little bit about this time-lapse imaging. So David had mentioned this before, This was developed by my group in 2014, where we were doing this in mice. And so this image actually shows a mouse tibia, right? And so when you image the mouse, the same mouse over time, you then register the images, and then you're able to see voxel by voxel comparing if there was bone formed or resorbed, so removed over these different time points, right? So what I wanted to do is try to implement this in HRPQCT in the patients, because to look at bone formation and resorption in the patients, what you have to do is you have to take there's two ways to do it. One is you take blood from the patient and you look in the serum for these formation and resorption markers, but it's a systemic effect, right? So you're not able to see locally if there's formation or resorption in a particular bone site. So to do that, you actually have to do dynamic histomorphometry, and that's where the participant would have to get a piece of their bone called a biopsy taken from their iliac crest, from their hip, I should say pelvis. And it's a really quite a painful procedure to take a little piece of bone out of this patient, and then you have to embed the bone in PMMA, which is a polymer, and then you process it and stain it. And actually, the patient has to take 2 different doses of calcine. It's actually tetracycline in the patients, and then that binds to the bone, and then you're able to measure, okay, how much bone has formed over this time point. There's really limited ways to look at resorption. So what we wanted to develop was this non-invasive imaging biomarker to measure bone formation and resorption, right? Which is what we've been doing in the mice, and now we wanted to do it in the patients. And so again, we used, as I mentioned, we had these participants, right, who did these repeated scans in the same day, right? So they underwent 2 scans within a 10-minute period. So there's no biological change that's occurred. So we can use these images from these 29 patients and look at how much error has occurred. So we can see how much mineralized or eroded volume has occurred over this 10 minutes. And we know that all of that is error, right? Because there's no biology happening. And so we first looked at using this method, this binary method, which is what we had been doing in the mice. However, the resolution, as I mentioned, or the voxel size is much better in the animal studies because we can expose these mice to higher radiation compared to humans. And so we saw when we implemented this method from these same-day repeated scans, we got a lot of error. And so with this just shows the first generation scanner and the second generation scanner, but we had 12%. This is formation and resorption, so about the same of both, and around 12% with the first generation and 8% with the second generation. So a little better, but still really high error. And so this is when we turned to using grayscale images instead. Now, we did a lot of examination of using these grayscale images with registration and density thresholds, Gaussian smoothing, periosteal mass. I'm not going to go into that because that's another 30 minutes of discussion. But just to tell you that what we were able to do was we were able to use the grayscale images and find a method where we could minimize this measurement error to an acceptable level. And so the next thing we wanted to do is we have this method now, and we wanted to try to verify it and validate it in some way. And so we used our repeated scans again. And on the same day we had these repeated scans, as I mentioned, we expect to see no bone formation or resorption. And so you can see here those repeated scans. And then what we had for each, so we have those 2 repeated scans, but what was interesting was we also had, those were taken at 6 months, we had a baseline scan that was also taken from that same participant. where we know that there's over this 6-month period, there is biological change. And so we could see with the one pair, we were able to show, okay, there is a significant difference between the repeated and so the baseline and the 6-month scan. And when we did the second pair, we were also able to show that there's a significant difference, right, between the repeated, where we don't expect change, and this 6-month scan. And interestingly, the two pairs were also not significantly different from each other. Okay, so we were able to really validate that our method was capturing true biological change rather than random noise. Okay? And if we just look at this visually, so this is the repeated scan in the patient, right? So any little spot here of the yellow is formation, the red is resorption, any spot here is error, okay? So there's not a lot of error. You know, there's some error, there's always going to be some error, but it's at an acceptable level. So now we have the pairs. So this is pair 1. So this is 6 months to baseline, and this is the other repeated scan with the baseline. So what we can see here is, you see the formation here, it's in the exact same spot. So we're able to see, okay, we are seeing true bone formation and resorption. So then we took this method and we applied it then to the 48 participants within the trial. So we took, I mentioned we had 112 to begin with, but we wanted to look at only a subset of the patients that had really absolutely no motion, and they also had scans throughout this whole time period. So they had scans. And this last part was we hit the pandemic, and so we did lose some people in the last 6 months of the trial. So we just focused on these 48 patients. And so we wanted to look at the bone formation and resorption, and we looked at the effect of the treatment dose while accounting for the scanner generation, the OI type, and also motion. And so here you can see the results from the total bone. This is total bone, cortical bone, or the trabecular bone, the two different compartments, for 2 intervals. So baseline to 6 months is shown here on each of the graphs. And then you also have 6 months to 12 months, right? So I'm just going to show you those 2 intervals. And this is for the radius, although we saw similar results in the tibia. But you can see that at baseline to 6-month interval, there was a tendency towards greater formation and resorption for the high dose versus the medium dose. And at the 6 to 12-month interval, the high dose treatment of cestrusumab had significantly greater formation and resorption than the low dose. So as I mentioned, this paper is actually under review. We're hoping it gets accepted, but this is a really amazing, non-invasive method where you can measure bone formation and resorption without having to take a biopsy, and use it to track drugs like we have done here, or even disease progression in patients. And it's not just for OI, right? We can use this for a lot of other diseases, chronic kidney disease, other diseases where we see bone formation and resorption changing a lot. And so the last thing I wanted to show you just quickly is one of the areas with most of the work that's been done with HRPQCT is really focused on adult populations, because it's used a lot with osteoporosis. We're using it in this rare disease, osteogenesis imperfecta, but most people are looking at elderly postmenopausal women, right, to look at fractures. So we developed a recommendation for how to scan kids effectively with this technology, and we published that last year. And we also put in some guidelines specifically for rare disease populations in kids. And you can see here our Schreiner's protocol and where we think you should be scanning the bones. Excuse me. So the last thing is, I just want to mention, so this is something that I'm doing right now, where I'm writing up a grant proposal for the Brittle Bone Disease Consortium. And what we're trying to do now is, image registration in kids is really difficult because the bone is growing, right? And so trying to track the same piece of bone over time becomes very difficult because there's no landmarks. And so we just showed briefly this proof of principle, but we're working on it now. I have a couple PhD students. This is part of their project. So kids with osteogenesis imperfecta actually get these bisphosphonate treatments, and they leave these sclerotic lines in the bone. And they're actually trabeculae from the growth plate that are kind of frozen. And so what we're using these sclerotic lines as landmarks to actually register the same volume of bone over time and follow that. So stay tuned. That's the next development, because we wanted to see how, looking at the same volume of bone, how that changes during growth and into adulthood. So I just want to thank my lab, but mainly I want to thank David for the preclinical study that was shown, and also Madi, who graduated. He was a PhD student, and he did a lot of the work. The latter part that I showed with the time-lapse analysis is all part of his PhD. He's doing a postdoc now, and also my collaborators. So we'll end there. Thank you very much.
Well, thank you very much for that wonderful presentation, David, Bettina, really wonderful. So any questions?
An hour.
So when you talked about the fact that there's a genetic heterogeneity with OI. Now, when you are doing those studies with the antibody to sclerostin, were you able to pass the different subtypes with?
Yeah, we didn't have statistical power to compare between the groups, but we could show that it was effective within the different subtypes. So you saw a tendency of improved in both the less severe and the severe types, but we weren't powered to actually compare between the OI types.
Okay. So
but there was a lot of heterogeneity. It was surprising how much heterogeneity was in the bones themselves, even within. So we would have someone who was less severe, but there was a large difference even within that group, and also within the more severe. So that was a surprising thing that we pointed out now in the literature, that it's not as defined, especially between the 3s and the 4s, type 3s and 4s.
Okay. So the other question, I'm just abusing my role here.
No worries.
So those studies at the clinical trials, they were not combination therapies. Has anybody does combination therapies with bisphosphonates and antibody to sclerostin?
So no, well, I didn't mention that, but we actually treated the patients with the sclerostin neutralizing antibody up to 12 months. And then after, there was a 1-year follow-up period from 12 months to 24 months, where it was at the discretion of the physician to decide if they wanted to treat the patient with anything else. So most of the clinicians gave the patients bisphosphonates. So like all the patients that were treated here at Shriners, at 12 months, they then went on Zol, so zoledronic acid. And what we're seeing in the 24-month data is it's really advantageous to, after sclerostin antibody treatment. And they saw this in patients with just regular osteoporosis, right? They saw that sclerostin increases bone mass, but then over time, it will drop again when you stop treatment. Right. And so the idea is to increase it, give them bisphosphonates so that they don't then lose bone mass. They don't get this increased resorption. And so we did see in the patients that had zoledronic acid, this bisphosphonate, they were able to maintain their bone mass.
Okay.
So So I think that's going to be, at least speaking with clinicians, that's the thought of when this drug is approved, that's how they're going to be using it.
Right. So my last question is referring to you are basically enhancing bone formation through Wnt signaling pathway,
Exactly.
activating the Wnt signaling pathway. And
Yes.
any thoughts about, because you're applying this to children, and any thoughts about the duration that you do this, because you are inhibiting sclerostin in children who are growing and adolescents. So any thoughts about how long this would be done?
Yeah, I mean, we're really at the early stages because, you know, they've only got this 6-month data in kids, but, you know, my thought is over a year, and then get them, and because bisphosphonates are also really important to have throughout growth, to do it concurrently, which is what I would, you know, what I hear from the pediatricians, because for this particular study, the kids that went on this study, the one I showed you, the preliminary data, they had to go off bisphosphonates, right, which is not ideal.
Right.
So I think in future, what they're going to do is they're going to stay on their bisphosphonates and then have intermittent sclerostin neutralizing antibody treatments over a year at the max.
Right.
That's what I foresee. I'm just, you know, speculating, but that's what I'm guessing is going to happen.
Great. So
and the bisphosphonates, one thing I should say is it actually relieves pain. So the mechanism is not known, but a lot of people with OI, they also, especially adults too, where, you know, bisphosphonates are not standard to give to adults with OI, but a lot of adults want the bisphosphonates because they also get pain relief.
Right.
So that's another thing, you know, the kids, not just to increase the bone mass, to also relieve the pain.
Yeah, it'll be interesting in David's experiment where he's looking at the mechanostat, so to see if you can use bisphosphonate or the sclerostin antibody.
That's something that would be very interesting, because we actually saw that, you know, in my study at baseline, the OI mice, they do have more resorption going on. And so I think it would be very interesting to see, you know, mice treated with bisphosphonates, presumably less resorption, and then see how that impacts their mechanosensitivity as well, compared to the wild types.
Yeah, and we actually know that bisphosphonates, there's some controversy in the literature whether it leads to enhanced or reduced a bone formation response to loading. So, whoops, oh, some little thing that came up. So yeah, that's definitely on the radar for for another future graduate student. Yes.
Yeah,
so.
That's good. There's a question in the chat. Anita, did you want to ask it?
Sure. Hi, I'm just like a little sick, so I might sound weird. But I was wondering about the bisphosphonates. I typed it earlier on in your chat when you were talking about how the density of the bone isn't necessarily the issue. So it sounded like, are we essentially causing any harm? Like, what's the point of using bisphosphonates? But you kind of just mentioned it earlier.
Oh yeah. Well, and bisphosphonates, look, in growing kids, this was that one earlier slide I showed. Maybe I'll go back to, I don't know if I can, but do I have to, hold on. Let me just zoom here.
You just go back to
here.
Yeah, if you just go back to basic.
Oh, basic. Oh, there we go. Okay. So if we go to here. Oops. So, sorry, should have just scanned in front, but right here. So actually, so the bisphosphonates are really amazing at preventing vertebral fractures, right? So they're really essential to have in these kids during growth. But because, you know, they're forming bone, and just through growth, you can block any kind of resorption going on. It's just in the long bone fractures where you're having these less favorable results, right? And it's just because the bisphosphonates don't increase the periosteal apposition, which is something that the cestrucimab, the sclerostin neutralizing antibody, has the potential to do, right? So that's why I think in future we could combat both the vertebral fractures and the long bone fractures with this combinational therapy. Is that clear?
Yes, thank you.
Thanks.
Any more questions, Mike?
Sure, yes, I have questions. It was a wonderful presentation, very impressive data. Very good, actually, what you guys did up to now. I just had some questions regarding, so in your animal models as well as in the clinical studies, so are there any changes in the quality of the minerals that are formed? So you mentioned you used bisphosphonates and sclerostin antibody. So does that change the quality of the mineralization, like the crystallization itself? And two, is there any changes in collagen, since osteogenic imperfecta has to do with mutations in collagen? Are there changes in the collagen content in your load, let's say in the loading in your animal models or in the treatments themselves?
Yeah. Do you want to take that, or?
Well, I don't know.
We haven't done that. Yeah. Well, we haven't done any testing in the mice, but we have a study that we just published in JBMR. It's in press, where we did take some bone biopsies. So from 6, it's a small number, but 6 of the patients in the clinical trial from the adults, we had bone biopsies taken, and we looked and saw, are there differences in all of these parameters? So we did Raman, Sachs, nanoindentation. So, you know, a lot of different parameters to look at, was any of the mineral or matrix properties changing? And we did not see any changes due to cestrucimab, except there was a tendency of a lower hardness, which we couldn't explain. But by and large, the cestrucimab is not changing the mineral properties. And we were able to compare because we had biopsies from OI adults. This was because of the Shriners had a repository of some biopsies that we were able to compare it to. So we had OI adults without treatment, and we also had healthy adults, amazingly. And so we were able to compare that and show that it's not changing that. So, and there's one other study that has published that I can't remember, the Hassler et al. And it's JBMR, where they, a few years ago, where they took some biopsies from people with sclerosteosis, so the genetic knockout, and compared, and also didn't see differences in bone quality.
And just about collagen, we know from second harmonic generation and things like that, that in OI, we actually see more disorganized collagen in general compared to wild types. And so you know, that's part of the sort of disorganization of the structure that we see as a whole. And also there's just greater room for mineralization as a result.
Yeah, but we didn't see, like, cestrucimab didn't alter the collagen orientation compared to the OI biopsies that didn't have cestrucimab. So there was no difference in that. So
Perfect, thank you.
thanks.
Thanks. Any other questions? Just unmute and ask.
Yes, thank you, Dr. Bettina, for this, and Dr. David for this amazing presentation. My question, does any effort to use this high resolution scan for other bone diseases with fragility in pediatric group rather than OI?
Yeah, well, I mean, as I mentioned, it's really mainly been used for postmenopausal women with osteoporosis, but in kids, there are, I know there's a group in Calgary that's looking at I think they're looking at diabetes, type 1 diabetes in kids. There's also some other rare diseases like Marfan syndrome they've shown. There was a group in Denmark that showed that kids and adults with Marfan syndrome have low bone mass. So it's, you know, it's increasing popularity. There's about 100 of these machines in the world, and we have one here at the Shriners. And so, you know, as the number increases, more and more of these studies are going to be done in these rare populations.
Thank you.
Thank you. Thank you.
So I may have missed it when David was talking about his loading. Was it just cyclic compression? Was there any tension there?
No, it was just compression. So we compressed, you know, cyclic compression once a day of the left leg, and then we had the right leg as well as an internal control that we used for all the results.
Have you done any tension or just compression?
We haven't done any tension, no. Yeah, that would be interesting to look at, I think, for sure. But so there's some research that's been done. You were an author on these, right, where they looked at the properties of sort of the bone matrix and OI on under both tension and compression.
Yeah, we did that. Yeah,
So
but that was more looking at the mechanical properties, under tension,
level,
the tissue at the ECM level.
Yeah, so tension would be interesting, but we've not done any tension.
Yeah, I mean, David has done some tension in healing.
Okay.
Right, with the accordion technique.
Yep.
But that was in regular. That wasn't in OI, right? That's what. Yeah. So so there was an accordion technique during healing where you compress and then tension. So that could be done in OI, and you know, look. The thing with OI in fracture healing is they actually have normal fracture healing, but altered or inhibited osteotomy healing.
Okay.
So, you know, so that's another area of his PhD is to try to understand why is the osteotomy healing altered and how is the mechanical environment affecting that.
That's wonderful. So thank you very much for really excellent work. And
thank you. It was really, really fun. Thanks for having us. Appreciate it.
Yeah. And thank you everyone for attending the seminar. Have a wonderful day. Bye.